So, good evening, everyone. Welcome to this webinar session on peri-transplant care in pediatric kidney transplant recipients. So, in this webinar session, the speaker is Dr. Stephen Marks, who is head of the Department of Pediatric Kidney Transplantation at Great Ormond Street Hospital. And he is a very renowned pediatric kidney transplant physician and has multiple roles. He is a IPTA counselor also, and he is editor in many journals and has several publications to his credit. And our chairpersons for this session are Madam Professor Dr. Umali, who is now senior consultant at SRCC Children Hospital in Mumbai. She is a teacher for many of us, and she has also multiple publications to her credit. She was former dean of BJ Wadia Children Hospital. The other chairperson for our meeting is Professor Dr. Beena Parikh, who is head of the Department of Anesthesia at our institute at Institute of Kidney Disease and Research Center. So now I request Dr. Stephen Marks to start his talk, please.
Good evening, and thank you very much indeed for welcoming me to your webinar. I would hope that we'll be able to come to India soon and visit you all, but in the interim, Zoom is able to transport us around the world, so it is good from that perspective. Thank you for the kind introduction as well. Can I check you can hear me, see me, and see the slides clearly? So I'm going to be talking about the perioperative care for children undergoing kidney transplantation. I'm going to start off just understanding some of the factors involved in determining the renal allograft survival and some of the data from the UK with my role in NHS blood and transplantation when I was overseeing all of pediatric kidney transplantation, and then talk a little bit about how to work up children, young people, as well as the perioperative care for children, young people undergoing kidney transplantation. So this really shows the 25-year review that we did of over 3,000 kidney transplantations in the UK, believing that preemptive living donor kidney transplantation is the way forward. And what we showed over the time interval was we had improved outcomes with respect to survival and growth, cognitive development, psychology, and quality of life. And of course, although we have very strong dialysis programs like you do in India, we do believe that preemptive living donor kidney transplantation gives children the best longer-term outcomes. So looking at our national data, you can see that the patient survival at 25 years is around about 4 out of 5 children. So many children have comorbidities, they have other clinical issues, so not all of them will die due to issues with the graft or risk factors such as having infections from immunosuppression, but the longer-term cardiovascular morbidity, mortality, as well as malignancy. And this graph really shows, like in many centres and in many national databases, that we've done a good job in the fact that over the last 30 years, we've got improvement in graft survival. So this is after children undergoing a deceased donor transplant, donation after brain death, or heart beating transplantation, where you can see the survival rates improving with time. However, I put this slide in basically as a challenge to us for the future, because actually what this shows us that if you remove the perioperative complications, which can be a result of hyperacute rejection, immunological, non-immunological, but many are surgical complications such as graft thrombosis, that actually, and obviously recurrence of disease as well, which we don't have time to talk about today, but obviously what you can see here is that actually we haven't made much inroads. And I think this really lays open to the fact that we need to do better and understand a little bit more with biomarker discovery helping us for the future. However, what we do know is that those younger children who get transplanted, the 10 and 15 kilo kids, the smallest we've ever done is 7.8 kilos, but around the world some people have transplanted 4.8 kilo infants. And I think usually that's because they can't dialyze them. Whereas I think it's much better to wait until the vessels are a bit bigger, which makes the surgical intervention and outcomes improved. But what this shows you that although the under 6-year-olds do worse initially, they actually get a catch up and they actually end up doing better, whereas it's the adolescent group with the developing immune system and non-adherence that end up doing better at the start, but have worse longer term outcomes in losing their allograft. So what has happened? Well, obviously we've got new advances in surgical techniques which have improved, but also I think really this stays the fact that it's the immunosuppression has really changed, and the outcomes that we're seeing with children, young people are much better, primarily due to that and with time. How about with living donor transplantation? Well, again, we've made great inroads over the last 30 years. Again, statistically significant difference in the 90s to the 2010 long-term follow-up. But actually, if you exclude failures within the first year, you can see that although it's just misses statistical significance, we are actually improving our outcomes in living donor kidney transplantation with time. So if you look at overall what I like to call the half-life of kidney transplants, which is how long does it take before half of your kidneys are lost, such that patients are requiring dialysis or retransplantation. And you can see here that we've got a survival benefit for living donor transplantation, which is significant, 5, 10, and 20 years, but gives an advantage, a half-life from about 16, 17 years to about 18 to 19 years with a living donor. And this is shown here with the data at 25 years with the renal allograft survival, looking at living donors as well as deceased donation of around about a third at 25 years. If we look at the overall long-term graft survival for our first pediatric living donor, you can see here the 10-year survival for patients is 96%, with the graft survival of 76%. And although that the patient survivals are the same in heart-beating donors, so donation after brain death at 96%, there's a reduction from 76 to 63% in the graft survival from deceased donors. And again, we can look at the data around the world, but this really has been mirrored by many, including the collaborative transplant study since the 80s, as I've shown in this slide. And again, the improvement in the half-life of kidney transplants really heading up towards about 20 years in about the latest cohort that you can see, so that the 20-year estimate is nearly heading up to 50%. But what are the outcomes? Well, I think we really have to think about what kind of kidney that you accept for your patients, which I know we'll talk about later, but looking at the race, the primary renal disease, so if you're at risk of recurrence, having a prolonged cold ischemia time, or the requirement of dialysis in the first week with delayed graft function, but also the better matching, HLA matching increases the chances of getting less immunological acute and chronic rejection. I think patients that are retransplanted or have an early acute rejection do worse, and especially as we've seen those in younger age and those when we accept deceased donors which are much older, because many of the deceased donors will have died with hypertension even if it was undiagnosed, resulting, for example, in intracerebral hemorrhage. So what do we need to think for our patients? Well, as you're working up, you need to consider making sure that they're immunized, thinking about what's the cause of their end-stage kidney disease. Do they have problems with vascular access, thrombosed vessels? Where is their dialysis access, their dialysis history? But taking a full medical and surgical history, specifically thinking about the vessels, the urinary tract, is the bladder safe for transplantation? Are they under other multi-specialties such as metabolic? What needs to be done from their perspective? Is there any personal or family history of bleeding or clotting tendencies? Do they have good cardiac function? And is there evidence of left ventricular or biventricular hypertrophy? Making sure that they're going into a transplant where their nutrition is optimized, where they're in a good psychological state, and making sure that you time the transplant where at all possible to be preemptive, but at a good time for that young person. So thinking about their age and size, their compliance, previous dialysis issues, and sometimes even the social circumstances may mean that you want to delay transplantation. So what do you need to think about the patient? Well, the primary kidney disease is helpful with the concern of recurrence and the requirement for nephrectomy. You need to think about the anatomy, so the body size and build, the vascular anatomy, so the vessels themselves, if there's any urological issues or bladder compliance. I'm thinking immunologically wise about the blood group, HLA typing, and immunology that you can see here. Obviously, consideration needs to be about virology, so thinking, has the young person been immunized for those viruses that we can, but also knowing about Epstein-Barr virus, thinking if it's an EBV naive young infant who's getting a transplant from an adult living donor, one of their parents, and it's positive, then the mismatch increasing the chances of getting a primary EBV infection and then developing post-transplant lymphoproliferative disorder. But also thinking about what kidney replacement therapy they've had, what's their residual urine output and blood pressure, and thinking about their general health status as well. So other metabolic respiratory conditions, cardiac status is really important. And then thinking of the donor details, trying to make sure that minimizing the mismatches where at all possible, looking to see if there's any evidence of preformed donor-specific antibodies, which develop earlier, but doing your tissue typing and making sure that you've got your cross-match and details, even if it is a virtual cross-match, in a low-risk transplantation. For a deceased donor, which we'll talk a little bit about, need to think about the donor medical history. If it's a deceased donor, the cause of death, what's the quality of the organ like? So thinking of the age, what's their peak creatinine? Have they had any kidney replacement therapy? What's their kidney donor profile index? Was it heart beating versus a not on heart beating, a DBD versus a DCD transplant? And then thinking about the other organs, what happened to the other kidney, and are the other organs going to be harvested and is going to impact in the cold ischemia time? For a living donor, well, hopefully they've gone through the medical and surgical checks as well as psychological. There's obviously a thorough evaluation to check the suitability of the donor, but things might have changed. So though the HLA match may have changed, is not going to change. You may have HLA antibodies, which of course are important to have a look. And then the consideration, if you've got a living donor, do you start your immunosuppression before the transplant, which does happen in some centres. So thinking about planning for the transplant, so you've got a patient who's come in for deceased donor, living donor, it's about making sure, as we do, is have a protocol which is individualized for that patient. So making sure you've had a decision about what immunosuppression you may use. Our standard is the TWIST protocol, so we use a 5-day weaning of corticosteroids with the understanding of giving intravenous basiliximab on day 0 and day 4, and starting on mycophenolate mofetil and tacrolimus with a reducing dose of mycophenolate mofetil at 1 week afterwards, 2 weeks after the transplantation. But obviously, if it's a high risk, blood group incompatible or HLA incompatible, we're going to have to consider antibody removal, at least with intravenous rituximab, and then thinking about the role of induction agents, plasmapheresis, double filtration plasmapheresis, or even immunoabsorption, especially in an HLA incompatible transplant. Everybody has their own protocol and other medications. So we generally would give aspirin for 1 week if it was low, so for 1 month if it was low risk, thinking about your anticoagulant therapies. We would only change if there was based on additional risks. Antiviral prophylaxis, so we would give valganciclovir if it's a CMV positive donor into a CMV negative recipient. Cover with antibiotics until you know that your cultures are negative, and giving proton pump inhibitors as well as protection. We'll also need to consider potential drug interactions. So if the patient, for example, is a metabolic patient, is on special feeds or medications, we need to think about what those drug interactions can be and discuss with the pharmacist, and thinking about changing the doses post-transplant with improving estimated GFR. So when we're thinking about the perioperative management, sometimes it's also looking at the child, so a 10-kilogram child, and thinking about if they've got gastrostomy, if they've got dialysis catheters. We've got one patient who also had a suprapubic catheter, as well as a PD catheter, a gastrostomy in situ, and really trying to work out where the transplant's going to go beforehand, especially if you've got mitrophanol and it's not around the umbilicus. Obviously, renal transplantation, we try in do many more extraperitoneal transplants than we did previously, a lot more intra-abdominal for the younger infants where their anastomose onto the aorta and IVC, but there is increasing evidence that more extraperitoneal can be done in smaller infants as well. And I include this because I think it's really important to show, for me, when people are talking about, what's the weight of the patient, well, I can get any patient to have an extra kilo if they're fluid overloaded, but actually what I think is more important is the length of the patient, and that would really correspond to the vessels and making sure that you've got a good diameter vessels, so looking at ultrasound and MR for smaller infants to try and gauge when's the right time to do transplantation. I put this up because actually knowing what your patient's systolic, diastolic blood pressure going into a transplant, but actually knowing what the donor's blood pressure as well and what that mismatch, because remember that kidney will be used to being used to perfusion pressure, which will be based on the donor blood pressure moving into transplantation, especially a living donor, where in fact we're able to accept more marginal donors. So historically, you weren't allowed to be hypertensive and be a living donor, whereas now you can be a well-controlled hypertensive adult on 2 agents, one of which is an ACE inhibitor. So I think we need to think about, when the patient's going down to theatre, thinking about and having discussions between the physicians and surgeons. Is it external iliac artery, veins, is it extraperitoneal approach, is it onto the common iliacs, or aorta and IVC in younger children, which, as I said, may be more intraperitoneal. I'm thinking about the anastomosis of the bladder and the ureter with the insertion of double J stents. Some places don't do that at all. We do still insert double J stents. Some places will actually insert the double J stent and will tie it to the end of the urethral catheter. So when the catheter is removed at around 5 days post-transplant, then the stent is removed, so the children don't have to go through another operation. I'm thinking that the risk factors for obstruction are definitely higher in the first week after transplantation. And I think the important thing is making sure that you've got people who are qualified. So generally as a consultant, we would go down with the registrar and the senior nurse looking after and looking at the patient in the recovery room. They may be in recovery for a long period of time. People still need to remember to give intravenous fluids. We would do a routine recovery room Doppler renal and bladder ultrasound as well. And I think looking at the patient when you see them, finding information about what's their circulation and perfusion, what's the blood pressure, the central venous pressure, the saturations. If they've got hypovolemia, making sure that you bolus them initially. The idea to try and see if you can keep the urine output high early post-operative. But knowing what's happened intraoperatively and how much urine is being produced, I think is really important in getting an idea of the overall fluid balance. I think it's important to know where all your lines are, your drips, your drains, your lines. What are they and where are they? We've got patients that have transversus abdominis plain blocks, so they've got another catheter which is infusing local anaesthetic around the time. I would always discuss with anaesthetists, but look at the records, see what has been documented with regard to blood loss, what the fluid balance is like, significant events during surgery. So did they have to bolus the patient intraoperatively, and if so, why? Making sure they've got adequate blood pressure control and pain control as well. I think it's really important to read the operation note, discuss with the surgeon, find out if there was anything that happened untoward during the operation. Did they have to sacrifice an upper pole vessel? Was it a long procedure with lots of blood loss? How many sites of anastomosis? And getting additional details. I would always want to know the cold ischemia and the warm ischemia time. So the time between the organ being removed from the donor to its insertion in the recipient, so the cold ischemia time, and then looking at the warm ischemia during the organ retrieval from the time of vascular cross-clamping until cold perfusion is commenced, and the ischemia during the implantation into the recipient, so from the moment of removal of the kidney from the ice pump until reperfusion. So I've worked and trained in North America, where many places the patients go straight to intensive care. We actually have patients who have undergone standard transplantation. If it's a extraperitoneal approach, it's onto the ILACs, a bigger child, then they would go to our high dependency bed in our own renal ward, where we closely monitor the urine output at least every hour with blood pressure, CVP readings and saturations, making sure that we're keeping the patient well hydrated and perfusion of the kidney. And we would give insensible losses, which is 400 mils per meter squared per day, plus the urine output, and replace that urine output initially. And then obviously if the creatinine is coming down nicer, you can then start thinking of putting onto a fixed target a few day or two after transplantation. I think it's important to think about your fluids with insensible water loss that I told you about, as well as early urine replacement and putting them in different lines, partially because if you're going to give potassium replacement, you want it to be in your steady, insensible water losses. You don't want to be in the situation that all of a sudden a patient becomes polyuric and that you're replacing the urine and it contains a high amount of potassium. So I think it's important to do the early urine replacement with insensible losses. I would always start at 100%, try and bring down if you can, expecting at least 2 mils per kilogram per hour for the functioning new kidney, plus at least the native urine output, and we're calculating what that was in mils per kilogram per hour. I would set kind of minimum and maximum rates, having reviewed the patient over the first few hours, although obviously you might need to watch out if they've got ATN, where you might put them on minimal replacement. And obviously, if they're polyuric pre-transplantation, then you're wanting to make sure that they don't get dry. So very often patients will be overloaded, and we've done a study looking at intravenous fluids, different types of plasma light versus standard fluids. And I think moving forward, the question is going to be how much fluids should you be giving kids? And I think we need to have more studies to understand what's the best and optimal treatment. So why set these maximum fluid limits? Well, I think some patients may have massive diuresis, especially those with good residual urine output from the native kidneys, and especially if you've got a living donor transplant, which works as soon as you hook it up to the recipient. But you need to think about changing the fluids according to the urinary sodium, the serum electrolytes, and always watching out for hyponatremia, which may be as a result of too much water, or in fact even too little salt, or a mixture of the two. And you may have sodium wasting due to a hypoxicemic injury to the graft. And this was a salutary tale of a patient when I was training at Great Ormond Street that we ended up publishing, which was a fatal case of cerebral edema with hypernatremia and massive polyurea after kidney transplantation. So what do you do if they've got gross polyurea? Well, one thing to think about at the start is actually to fix the intake. So there's a maximum, maybe 10 mils per kilogram per hour, and then going back and reassessing and seeing what it is and the balances afterwards. Look at frequent fluence balance and clinical review OBS at least every hour in the first few days after transplantation, keeping a close eye on the neurological status when they're hypertensive and bradycardic. We'd use half normal saline as a base, but it does depend on the urinary sodium, approximately 80 millimoles per litre, and any boluses would be in the form of normal sodium chloride and normal saline 0.9%. So I think the thing to consider is what to do if the urine output tails off. Well, it really depends on the clinical status of the patient. If they're fluid overloaded and warm and well perfused, and considering giving a dose of diuretic. Remember, if it's a living donor and they are producing urine, then actually a small amount of furosemide may be all that's needed just to kickstart. Making sure that you've decided beforehand what blood pressure you're aiming for to allow relatively high BP to ensure adequate perfusion. If it is too high and we're running into problems with hypertension, then you might want to give furosemide, and then obviously making sure you're watching the trend of the electrolytes, sodium, potassium, phosphate, and magnesium. As I said, we would do an ultrasound initially in the recovery room, and then we'd basically monitor to see any change in progress before repeating it. So I think, taking this all on board, pediatric kidney transplantation is highly specialist. It requires careful planning. We need close collaboration with the laboratories and multidisciplinary teams. Many decisions are very complex. We need good advanced planning and vigilant clinical reviews postoperatively to make sure that we're able to make the best decisions which are for our own individual patients. I've just put in some references here from some of the work over the years, and very happy to answer questions. This is one of our adolescents who held the torch for the Olympic torch. I thought it was appropriate to put this in since we're in the middle of the World Cup. This is our team who are going to our transplant games, who compete nationally, showing kind of good quality life that our children and young people can have after transplantation. And I'm happy to answer any questions. Thank you.
Thank you, Dr. Marks, for that excellent talk. Now I would ask our chairpersons, Uma Ali Madam and Dr. Bina Parikh, for any comments or questions.
Thank you, Dr. Marks, for this excellent talk in such a short while. I had a few queries. One is related to the intra-op use of vasoactive drugs. Often in smaller children, most of our children, even when they're older, a little small in size, and to maintain the blood pressure equivalent to the donor, what would be your choice of vasoactive drugs if one needs one?
Yeah, I've put some slides together as well that I can show some of the things to consider kind of intraoperatively in case you wanted to do. So I think one of the first things is considering gas versus intravenous induction. So we have discussions with the children, young people beforehand, before they go ahead, making sure that you've discussed what their hydration is. So if they're on dialysis, we'd like them to be a little bit wet going into the operation, but we don't want them too wet. So they might get a short spin of dialysis beforehand. Thinking about what invasive lines. So we generally would not put in arterial lines in bigger children, and would aim for non-invasive blood pressure monitoring, thinking about their fistulas and moving forward. And I think, as you said, one of the things to consider is really trying to get the volume replacement in that you can. And we would use central venous line and monitoring to do that. We've had a recent study which has made us use plasma light a lot more as fluids intraoperatively, thinking of them being, thinking about warming and temperature monitoring of the patient, and then making sure that you're monitoring the cardiac output and seeing how much losses that you've got during the operation is just as important as after the operation. And then, as you said, what to try and think about is to think about the fluids that you're giving. As you know, you've got to be careful in monitoring intraoperatively the blood pressure as well as the glucose and the sodium. So we would do it on iStats and then come out with that. For the most patients, they wouldn't require any addition, but if there were some issues, then we would start dopamine as the first vasoactive to see if there's a response, especially interoperative and perioperative management.
Sir, I have one question. We have always debate between pediatric nephrologist and anesthesiologist about the what should be the hemoglobin during the preoperative period. So because we are going to put a kidney of adult, so it is going to take around 500 ml of fluid volume. So there will be naturally anemia, and which can lead to hypoxia of the kidney and delayed graft function and ATN. So there is always a debate, and we are not able to come to the conclusion. So we need real guidance from you.
Yeah, it's a very interesting question. I'm afraid it's not very evidence-based if you look in the literature. There's two bits to consider. One is the real preoperative. So you want to be in a situation where patients aren't getting blood transfusions, either before surgery, so because of the risk of developing HLA antibodies, and that might preclude your living donor, which I have actually seen in my clinical practice before. So we would always aim for better anemia control. So leading up to even a preemptive, or if a patient's on dialysis, we would be making sure that they had adequate iron replacement. If they're on hemodialysis, they would be getting intravenous iron, and together with darbepoetin, and we would be aiming to ensure that their hemoglobin was around about 100, 110. Again, it depends on the age and the size of the patient, but where we can. If you're in the situation where a patient was anemic and it was between 90 and 100, we would still accept. We do talk about it and try and see if there's anything that we can do to maximize. We've had some patients, for example, who've had anti-EPO antibodies. So we've ended up having to change their preparation, but some of them have actually gone into transplantation with slightly lesser hemoglobins than we would like. But obviously, actually, the transplantation immunosuppression usually reverses that, and their hemoglobin, normalizes perioperatively as well. But really difficult to answer and not very evidence-based, I would have to say. So thank you for that question.
So if the recipient is very young, like maybe less than 5 years, around 10 to 15 kg, so what would you suggest? Do you routinely give blood before release of clamp, or how do you decide about it?
Yeah, we try not to give blood transfusions where we can. So it'd only really be if intraoperatively that there was a massive blood loss, that there was a problem, basically because of the issues about giving donor blood. We don't have the availability of giving the same donor blood as the donor organ in the UK, but I know some places do that and therefore feel that's less risky. So we would, when we do transplantation, we did up to 40 last year. None of them actually received a blood transfusion perioperatively. So it is very rare for us to actually require to give blood. We would be giving colloid if there was issues. So yes, we can give albumin solution perioperatively. You're worried about, as you said, about is your hemoglobin a true drop? Is it dilutional? So just closely monitoring and seeing and making sure. I always ask the anaesthetist what the estimated blood loss is, and not just rely on the surgeon to tell me. It's quite good to see what the anaesthetist thinks about the blood loss as well, perioperatively. And obviously you can use a cell saver as well, where you can give some of that blood back, which I think is important.
Do you do routine arterial BP monitoring on the table?
So we try not to do arterial monitoring as much as we did historically. Interestingly, there's been an international survey which we've just done, and most units still use intra-arterial lines. Our concern is going to be longer term and thinking about arteriovenous fistulae. So you're wanting to preserve vessels really as much as you can. I think for the smaller infants, yes, that we will put in arterial line, but to be honest, most of them we would remove unless they were going to intensive care. So if they're going to intensive care, I think it's fair enough. But if they're coming to our ward, then we would remove the arterial line and rely on non-invasive blood pressure monitoring on the ward. And that trying to minimize the longer term risks and complications as well.
One question, Professor Marks. I find it very difficult to chase a CVP of 10 in a spontaneously breathing patient.
Yeah.
And it often leads to fluid overload, trying to get those numbers right. So is it really necessary to chase that number?
That's a very good question. And we argue this a lot. One is the CVP right? So obviously resetting it, checking again, and then you still get it low. I think that it's always very difficult because obviously everybody's got protocols and you put down you're aiming for this and aiming for that. And I think sometimes you lose the bigger picture. So if you've got, for example, an adult living donor, blood pressure of the donor is 120 millimeters of mercury systolic going into an infant whose normal systolic blood pressure is 60, 70, then that's very different than that kidney going into an adolescent whose blood pressure is normally 110 to 130 millimeters of mercury as well. So I think that, for example, it's different for living versus deceased donor. It's different if you've got primary function or delayed graft function. So if you are putting in a good living donor preemptive kidney into a recipient where you can see that the creatinine is coming down beautifully, that you're maintaining a blood pressure, the patient's remaining warm and well perfused, like you, I wouldn't be chasing that CVP because you're in the situation where actually that you know that you're winning. The chances of getting thrombosis are low because of all your other perioperative management. And I think that I would accept a lower CVP in that instance and not chase the number when you know that the transplanted kidney is working and you've got a good blood pressure. So I agree with you. I think you have to look at all of the parameters together, yes.
One question I had, which is the kind of patient in which you would use a post-op anticoagulation? I mean, do you ever use it like?
Yeah, so we used to use a lot of intravenous heparin, and we've published on this as well. We changed our protocol where we didn't do routine procoagulant testing in everybody to being on selected individuals where there's either a personal or a past medical history or a family history of either bleeding or clotting tendencies, including postpartum hemorrhage requiring blood transfusions, including kind of DVT in the mother, for example. And what we do then is we just have patients on aspirin. If we then do a screen, we would do a full prothrombotic screen looking for lupus anticoagulant in addition as well, as factor assays, as well as genetic predispositions, so MTHFR, looking at prothrombin gene mutations as well. And if there isn't any abnormality detected in the child and there was no problem, for example, if there was a family member and they had a normal screen, then I wouldn't do anything different. It would only be that if we find multiple risk factors. So we know, for example, patients in chronic kidney disease and end-stage kidney disease will have an elevated factor VIII level, which will be due to endothelial activation. So I wouldn't change anything based on that. But if they had a genetic mutation, then I would think about introducing heparin. And normally the protocol I would discuss with hematologists and the surgeons before the operation. But to give an example, one way to consider is after the operation, if you're happy that there's been no blood loss, could you give some intravenous heparin targeting APTT, but actually in a lesser risk child, we would give a set standard dose and then convert to subcut heparin with the addition of aspirin as well. So I agree, yeah.
We'll ask Dr. Sahnaz to start the case presentation, please. Dr. Sahnaz is assistant professor at our institute at IDKRC, Ahmedabad.
Good afternoon, Professor Marks. Good evening, Umali Madam and Beena Parikh Madam, and to all senior faculties and colleagues joining us online. Without much ado, I'll begin. Quickly summarizing the case from last time. So a 4-year-old male who had red flags early on in the form of oligohydramnios and a low birth weight, but went unaddressed until 4 years of age when parents noticed that the child had developed reduction in the urine output with facial swelling, easy fatigability, vomiting, and loss of appetite when they consulted a local pediatrician, and ultimately the child was referred to us when underlying renal problem was identified. With us, when a detailed evaluation was done, it was revealed that the child had failure to thrive in the form of a reduction in weight for age and height for age, both less than -2 Z scores. The general examination revealed findings in the form of metabolic acidosis, acidotic breathing was present, hypertension was documented, child had pallor in addition to edema, and the biochemical workup did conclude that the child was actually suffering from chronic kidney disease, which had progressed into end stage. Both the kidney sizes on radiogram were small, 3.4, 1.7, and 3.3 into 2.2 centimeter sizes, which were both less than -2 Z scores. So we were dealing with a child who had early on alerting signs in the form of oligohydramnios and low birth weight, but was missed, presented with failure to thrive, hypertension, anemia, and kidney failure, secondary to bilateral small dysplastic kidneys. So when the child came to us, we were quick to start continuous ambulatory peritoneal dialysis. CAPD catheter inserted did not serve him much good because of recurrent episodes of peritonitis. And after a duration of 7 months, the catheter was out and we had to transition to maintenance hemodialysis. The access was right IJB. AV fistula was attempted, but because of the small size and the vessels were quite delicate and tiny, maturation failure occurred, and we tried to push through the right IJV as the access for maintenance hemodialysis, but there were complications which was quite anticipated: catheter-related bloodstream infections, poor fluid management, resulting in pulmonary edema and hypertensive emergency episodes. Also, 2 PCV transfusions were required during this course, pre-transplant, which were major sensitizing events. Renal replacement therapy, definitive management was obviously transplantation, and the family was counseled for same, but they lost 1 year of age, 1 year of time, sorry, because of various issues. And ultimately, by the time the child was registered under SOTO, he had already won a tumultuous year of renal replacement therapy on CAPD and dialysis. So pre-transplant immunology workup, HLA typing was done, PRA, panel reactive antibody test was done, which showed a positivity of 2% for class 1 and 7% for class 2. And a screening test in the form of multi-antigen bead assay revealed positivity for class 2, which was followed up as per protocol with the single antigen bead assay, which showed some immunological activity in class 1 in the form of B45 anti-HLA antibodies in a range of 2,500 MFIs. Other than that, class 2 activity was mostly quiescent. So pre-transplant challenges were the delay in diagnosis, the RRT modality and access-related issues worsened the course, and again, anemia was difficult to manage with hematinics and erythropoietin alone. PCV transfusions had to be given, which were sensitizing events pre-transplant. Chronic hypertension because of poor fluid management, resulting in left ventricular hypertrophy, again pushed the child into a vicious cycle, culminating into poor growth and nutrition. And delay in registration of cadaver organ donation, 1 important year lost, but thanks to SOTO, which prioritizes children, and the child ultimately ended up receiving an organ offer 3 months after getting registered in February 22. So a 40-year-old female who had sustained head trauma due to road traffic accident, did not have any other comorbidities, and was well maintained on inotropic support, a single inotrope required, and had a creatinine of 1.1 milligrams per deciliter at the time of organ offer. So we were quick to say a yes, and going ahead, HLA match was expectedly low, but the cross match was quite favorable with the CDC cross match, LCM 10% and AHG 12%, our cutoff being 20. We interpreted this as negative. The flows were also both negative, and we ended up saying a yes. So, although quite lucrative, the task uphill had just begun for us. Immunosuppression was obviously a very important concern, but more eminent issues were the anesthesia-related issues and the surgical issues, peri-transplant. BP monitoring is a Herculean task, and NIBP was the only option left for us because invasive BP monitoring was difficult. One arm had AV fistula and the other arm, most of the veins and vessels had been compromised because of sampling and stuff. And CBC access was also another concern, but luckily we had the right IJV in situ and we managed fluid administration as well as central venous pressure monitoring through that. The volume of fluid to be administered would be a very precarious decision here. A small child receiving an adult organ, so ensuring that the adult organ is well perfused was a major concern. Drug doses is an issue, but since our unit deals with a lot of pediatric patients, our anesthesia department is quite efficient in managing drug doses in very tiny babies as well. The surgical issues that were of major concern were vessel selection. 5 years, 11.2 kilos weighing child receiving an adult kidney, the vessel size discrepancy would make the selection of the anastomosing vessels quite challenging. The position of the graft also with a tiny baby, the ideal position for a transplant kidney would be extraperitoneal, but in cases where that is not feasible, intra-abdominal, intraperitoneal positioning or stage closure were the possible options that the surgical team contemplated. There was increased risk of thrombosis, which was always at the back of the mind because of the vessel size discrepancy. With this, I had already asked the first question to our eminent speaker about the minimum weight which their institute agrees to go ahead with transplant for. Sir, could you please just sum it up for us again?
Thank you very much indeed, and thank you for an excellent summary and a very, very interesting case. So as you said, it's a 4-year-old child, oligohydramnios, presenting chronic kidney disease going into end stage. My initial questions with the case would be that obviously the diagnosis of bilateral renal dysplasia as part of congenital anomalies of the kidney and urinary tract, you can get a secondary FSGS and proteinuria, but and you said it was nephrotic range proteinuria. How high was the urine albumin to creatinine ratio? What was the serum albumin in the patient?
The serum albumin was always more than 2.5, sir, 2.8 at the time of presentation. And the UPC ratios were also borderline more than 2. And on the dipstick, the urine protein was +3. Okay.
I mean, we do see that, but it is unusual. So I always keep that in the back of the mind. We would generally, obviously, if the patient's already on, requiring dialysis, we wouldn't advocate doing a biopsy. But if it was chronic kidney disease and significant proteinuria, we probably would do nephrotic syndrome panel just to be sure. And obviously, we'd be in the situation where we would consider doing a biopsy if the patient was in CKD, but not, as you said, if they're requiring dialysis and the kidneys are small and fibrotic, as you described, the risk of bleeding would be high, so we wouldn't advocate a biopsy at that time. So we would do your usual management, as you said. Obviously, your hypertensive emergencies, so you would be thinking of fluid overload with salt and water retention being the issue, but knowing actually you had significant hypertension at presentation with microscopic hematuria as well, you said?
Yes, sir.
So you would just be keeping in the background whether there was an element of a burnt out glomerulonephritis causing that as well, especially because we try not to transfuse our patients with PAT red cells before transplantation, as you said, because they can get sensitized. As you described, you required 2 transfusions. So we would manage this child, as you said, on dialysis. The smallest weight we would have to proceed to transplantation would be 10 kilos, although the smallest we've ever done has been as low as 7.8 kilograms. In the literature, there have been transplants in infants weighing only 4.5 kilos. But I always think that you are better, because of the concern with the vessel size, to try and manage them with additional nutrition and making sure that you grow them well during their dialysis. But sometimes people end up doing transplantation early because they're running into dialysis issues. Although I think invariably you can almost dialyze most children, as you said, if you're running into problems with peritoneal dialysis and moving on to hemodialysis. The question, though, about the weight, as I said, is one thing, but to me, sometimes it's actually the length of the vessels, as you've described, the risk of thrombosis. And of course, that's more likely going to be related to the height of the patient. And as you said, in your child, both with faltering growth and failure to thrive, the child was small and appropriately sized, as you said, as well. So that is what we would do. I would say that your kind of management and getting a kidney transplant, obviously we would aim for a preemptive transplant where possible. This wasn't possible in this case. And we would aim for a living donor transplant where possible. I would be interested to know the blood groups and the isohemagglutinin titers in the recipient, because very often actually in small infants, as in a 4-year-old, they usually have produced some antibodies, but actually the titers may be low, and actually doing an ABO-compatible living donor transplant actually may be pretty low risk as well for a consideration. And the reason I mention that is because you mentioned in your HLA matching, you said that it was only 1 out of 6. So in the United Kingdom, and very much in Eurotransplant as well, there is a push to try and get as well matched as a kidney as you possibly could. So even if I listed a child for a deceased donor transplant and said I was happy with a 2-2-2 mismatch, which means I would be happy to accept any immunological mismatch at A, B, and DR, the way that the algorithm is based, we would never be offered a kidney which only had 1 antigen match, unless it was a super urgent case that we put on where we were saying that we would accept the next kidney possible. So your question about blood transfusion is very interesting. So what hemoglobin level would you expect? Well, we would want to try and aim for a hemoglobin of 100 grams per litre or 10 grams per deciliter. We would be in the situation of trying to maximize iron supplementation. If there was a problem, we would go to intravenous iron administration with giving erythropoietin stimulating agents as well, so darbepoetin. I would hope that we'd be able to get the hemoglobin up. If we weren't, then I'd be doing investigations to try and work out, for example, is there problems with adherence, which is why we would go to intravenous iron. And would there be any issues with this patient, for example, in developing anti-EPO antibodies, so potentially changing to a different agent, and also checking for anti-erythropoietin antibodies in the recipient. But generally, because you might get a bit of dilution and loss of blood perioperatively, it would be good to try and get the hemoglobin to around about that level. You then asked a question about strategy for poor cardiac function. Again, it depends what the ejection fraction is and the fractional shortening is for those patients. I have to say that I have been referred a few patients nationally and internationally with this. And invariably with those patients, I would advocate trying to work out what the etiology is of the cardiac dysfunction. So is it because of undiagnosed chronic kidney disease, salt and fluid overload with time, and left ventricular hypertrophy, and looking to see if it's concentric left ventricular hypertrophy. I think also in these particular cases where the cardiac function is very poor, I would be worried with pump failure putting a precious kidney into that situation, invariably what I've done is refer the patients to have home hemodialysis. And the reason for that is so that they can have longer potential dialysis sessions more frequently than we can offer. You know, traditionally we offer 4 hours of hemodialysis in hospital 3 times a week. We can go up to 4 times a week. Anything more than the 16 hours is possible, but depends on staffing and number of patients. And if it's feasible to consider home hemodialysis, where you can have patients, for example, on nocturnal hemodialysis, you can remove a lot of fluid, and you can be in the situation where you get cardiac remodeling and seeing huge improvement in the cardiac function, and then being in the situation of being able to transplant at that point.
Okay, thank you, sir. 2 clarifications I would like to make. First is about the nephrotic range proteinuria. I did not highlight that much, but definitely nephrotic syndrome was a possibility as the underlying native disease, and we did work up for glomerulonephritis as well. We did a 24-hour urine collection and identified that the proteinuria was not significant. It was around 300 milligrams in 24 hours. Obviously, the child had progressed to end stage by that time, so that was one thing we had to keep at the back of our mind at the time of transplantation. Other immunological workup was also done, and the ANA panel, etc., was not suggestive of any immune-mediated glomerulonephritis.
I think that's important always to right, on the back of your mind, right, is the etiology. And we've been in the situation where, of course, if it was a nephrotic syndrome, is considering, do you undergo bilateral native nephrectomy pre-transplantation in order to be able to diagnose a potential recurrence of disease post-transplantation, which is important. So I think it's important, as you said, to be sure.
Correct, sir. So genetic analysis would have been ideal in the situation, but because of poor affordability on the family's end, we were not able to do it at that time. So that is one thing which has been missed for this case because of financial restraints.
I completely understand.
Yeah. The other thing is about the dialysis, the home dialysis, which you had suggested as intervention for children with poor cardiac function. We did attempt hemodiafiltration for very tiny kids, similar 2 cases, both of whom had FSGS progress to CKD. But unfortunately, both of them succumbed before we could do a transplant. So what is your experience with hemodiafiltration?
So hemodiafiltration, HDF, as you know, we do quite frequently in our unit. Professor Schroff, who's one of my colleagues, kind of leads our dialysis unit and has a lot of experience and has done quite a lot of research with 4H study, looking at the outcomes. And we definitely see the HDF is of benefit to many children pre-transplantation. So as I said, it's something that we very, very much advocate in our centre. The home hemodialysis, as you said, is even more specialised. It's not available in all centres and all countries. But the technology is definitely improving. The machines are getting smaller and more portable. So it's becoming akin to peritoneal dialysis and being able to happen in other places. You don't need special water supplies. We used to have to modify patients' houses when I started, when we were introducing other forms of home hemodialysis, but the machinery, as I said, is much improved. And it is mainly, I think, the timing of the length of dialysis that you're giving a child over the week. And even if you go back and read some of the adult literature in dialysis versus transplantation, you begin to see that the long-term cardiovascular mortality improves hugely with home hemodialysis compared to peritoneal dialysis, CAPD, and in-center hemodialysis in adults. And I'm sure that is because of the increased fluid removal, removing the toxins for more periods of time and actually improving the longer term cardiovascular outcomes for patients. And I'm sure, obviously, children, it's very different looking at arterial sclerosis and their vessels, atherosclerosis. In adults, it's very, very different in children. And I think we're in the situation that we will learn more with time. But I can definitely say that those with very significant poor cardiac function, we've seen their cardiac function improve, reversing of concentric left ventricular hypertrophy, improving of blood pressure control, and stabilizing the patients before transplantation is of benefit in those that we previously historically were very worried about.
Right, sir. Thank you. So moving ahead, we proceeded with the transplant on 15th of February. And for us, the child was optimized by now with a hemoglobin of 12 grams per deciliter. His blood pressures, although on the higher side, were quite favorable at this point in time because we were trying to push the blood pressures to the adult values, so to say. With a CVP of 7 centimeters of water pressure, we were happy to go ahead with transplant, and biochemical parameters also were well optimized with potassium and bicarbs fairly within limits. At this time, once a child was inside the OT and induced, IV methylprednisolone induction agent 100 milligrams was started, and IV grapholon infusion was also started, which was intended to continue over the 4-hour duration of transplant. Further fluid administration during the next 2 hours, we gave 800 mLs of fluids, crystalloids. Normal saline was given over a duration of 4 hours, which is 80 ml per kg of fluid administration in 4-hour duration, along with 100 ml of 5% albumin colloid given simultaneously, so as to bring up the blood pressures to 126 by 80 and push the CVP up to 10 by second hour into the surgery. At this time, the graft was put in place, and anastomosis between the renal vessels and the common iliac vessels, as deemed appropriate by the surgical team, was started. By the time the clamps were released, the cold ischemia time was around 18 hours. The CVP, we were able to push up to 15, and we preemptively started PCV administration so as to ensure that adequate graft perfusion was maintained while the cardiac output was diverted towards the newly transplanted organ, and simultaneously hemodynamics were stable. IV mannitol and IV Lasix were given just before the clamp release. Immediately after, as is the protocol, within 10 minutes of clamp release, we do a repeat, we do a blood gas analysis, and that showed a hyperkalemia and metabolic acidosis creeping, and appropriate correction with glucose insulin drip and IV soda bicarb was started. So by the end of the 4th hour, we had stable blood pressure of 124 by 72, and the CVPs were 12. Now we were happy with that. And the hemoglobin of 10.4 grams per deciliter after PCV was given was reassuring. Potassium had come down to 5.2, bicarb was okay with around 19, and on-table urine output of 300 mLs was quite reassuring. So what tools do you employ for monitoring intraoperative hemodynamics? Sometimes we are faced with situations where central venous pressure monitoring is very, very difficult. We have kids who have had both their IJVs, thrombosed and stenosed, and we are not very happy to put a subclavian line. So in these situations, how do you monitor the central venous pressures?
Can I just ask you a few questions just before I answer those?
Sure.
Can you tell me what was the weight, height, and the centile of the patient at the time of transplant, and was the patient anuric going on to transplantation?
The patient was fairly oliguric with hardly 50 ml of urine output a day, and the weight was around 11.5 kilos, and the height was 95 centimeters.
95 centimeters. And what was the weight you said?
11.2 kilos, sir.
11.2. Okay. that's fine. So was becoming oligoanuric by this point.
Yes, sir.
Okay, that's good. So the questions that you're asking, obviously, about the management are fairly difficult to answer because we don't have a very good evidence base. We are trying to do clinical trials in the United Kingdom looking at some of these questions about what is the ideal interoperative management for patients. And in fact, there's been the setup now of the anesthesia network for kidney transplantation in children, so ANKITC, which is part of a European initiative as a work group to try and improve the perioperative care for pediatric kidney transplant recipients. And they launched a website back in September, which I'd be very happy to share with you as part of the group in the Netherlands working within kind of Europe and internationally. And it really has come about because we are in the situation where we're trying to work out what's the best management for these patients. So one of the things which, of course, you ask is what do you do for monitoring patients? So many people will insert arterial lines in every kidney transplant recipient as they go into the operating room by the anaesthetist. But in fact, I advocate trying not to do that because you're obviously in the situation where these children will become hopefully adults and their lifelong kind of vascular access is important in considering, for example, arteriovenous fistula for hemodialysis in the future. We invariably will go for central venous pressure monitoring. So if patients have got a permanent catheter in for hemodialysis, which of course is the minority, but most patients will have insertion of a central triple lumen central venous line to go ahead for the transplant. We are in the situation where patients such as this one that you've described with nephrotic deranged proteinuria, we will have done some imaging of the vessels beforehand, partially to kind of ensure that the anaesthetists are happy to proceed to putting a line in. And we have been in the situation before where we will put in an interventional radiology central venous line a few days before the transplant to get access because of thrombosed or difficult vessels. And sometimes that can actually be of benefit when you are in the situation that you have a planned living donor date. You then asked the question about where do you put it? Well, I definitely wouldn't put a femoral line in around the time of transplant. You've just done your anastomosis to your vessels, to the common iliac vessels. So I'd stay well clear of the femoral vessels beforehand. We would consider, as I said, if we had, let's just say worst case scenario, we found that there weren't any access, we would consider putting in a PICC line, so a peripherally inserted central catheter, so maybe going through the brachiocephalic vein and then going up and going a little bit more centrally so that we can get a bit more access into the vascular. But yes, you are right that there have been some really tricky cases that we've managed to go through with large pore peripheral venous catheters, but mainly that's been in the addition of PICC lines. So part of the reason, to answer your third question about this anesthesia network, is a discussion about which fluids to give. And we've just finished a randomized controlled trial in the United Kingdom where we have randomized patients to receiving plasma-light solution as opposed to kind of intravenous normal saline, half normal saline. We are in the situation where I think the next question we've got is how much fluid do you give? And the problem is it very much depends on the donor recipient mismatch in my view. So are you putting in a kidney from kind of a healthy 30-year-old parent that's a 6-foot rugby player with a systolic blood pressure of 130 millimeters of mercury into a small infant who's on dialysis, that you're having to give midodrine to get the blood pressure above 60 before heading into the transplant, because obviously there's that mismatch of blood pressure, and you're putting in a kidney which is used to having a systolic blood pressure of 130 and being in the situation where you're not going to necessarily be able to achieve that. So for me, it is very difficult, and we would individualize that according to the patient. And one of the most important facts to ask the anaesthetist and to ask the transplant surgeon or urologist, whoever, the implanting surgeon, is, did the kidney ever go dusky? Because invariably, if the kidney goes dusky intraoperatively and they raise the blood pressure to, for example, 100 millimeters of mercury systolic, and say it was at that point that the kidney turned pink, I use that in my post-transplantation management to be able to say that I want this recipient's blood pressure to be above 100 millimeters of mercury systolic, because I know that below that, the kidney wasn't looking so well, and obviously increased risk of thrombosis. If you've got intraoperative hypotension or hypertension, it's important to monitor that. And if the blood pressure is too low, then our anaesthetist would be giving more and more fluid to try and see if they could elevate it. If we're in the situation that that doesn't work, then some renal dose dopamine on the table would be appropriate. If you're in the situation of having a patient and their blood pressure going into the transplant is too high, and I've been in the situation when I was training outside the United Kingdom, where I had a patient who was in intensive care, who was on a labetalol infusion for resistant hypertension, and we got the offer of a deceased donor transplant. And I have to say I was a bit reluctant at the time as a trainee to accept, but I learned from that experience that we were able to do the transplant, and it worked out well for that particular individual. So I do now think that we're in the stage where obviously you have to want the blood pressure to be optimized as much as you possibly can before the transplant, but we can be in the situation that you're running into individual problems. You then ask, what about patients that you're having issues with hypertension intraoperatively? And we generally see the hypertension can occur in the immediate kind of peri-transplant, post-transplant period. So my view is that if the central venous pressure is normal, then I would usually just start a little bit of vasodilatation with hydralazine, and I normally start at 0.15 milligrams per kilogram, so 150 micrograms per kilogram intravenous, slowly over about 1 to 3 minutes. Some people would go for an nifedipine. I do worry about precipitous drops in blood pressures initially, but the reason I use the CVP, because if you've got hypertension and you've got a low central venous pressure, then the hypertension may actually reflect vasoconstriction in response to hypovolemia, so in which case that we would want to give more fluids in that instance. If the hypertension was then persisting and the patient was adequately vasodilated, then giving regular antihypertensive agents. And especially if patients in that situation, I'd consider trying to titrate with labetalol infusion, especially if they're tachycardic, because labetalol's got both alpha blockade and beta blockade and a short high life, and you can basically titrate the infusion to the clinical response. And normally I would infuse at about 1 milligram per kilogram per hour initially and go up to about 3 milligrams per kilogram per hour. So I think that would be my consideration for those patients. And then you were asking about ventilator pressure requirements as a guide to fluid assessment, so having reactive airways versus pulmonary edema. Well, I think, to be honest, one part is we are quite careful at managing patients peri-transplantation. So we'd want them to go into theatre Not overloaded, but we would want to keep them more on the wetter side so that there's more fluid intravascularly going to help perfuse a very precious transplanted kidney. We are in the situations where we've had patients who we've tried to manage medically, but invariably, especially if we have a larger child over 20 kilograms, we're not having the anastomosis to the aorta and inferior vena cava, and we're not doing an intraperitoneal transplant, that we would actually extubate those children and let them come to the ward. If they're smaller infants, or especially if the anastomosis is onto the aorta and IVC, we would want to keep them wet for their kidney, but invariably, as you said, you might be in the situation that they develop a bit of pulmonary edema. And I think that we try and minimize the amount of respiratory support that we're giving, but trying to maintain normal gas exchange. I wouldn't just use the ventilator pressure requirement, because it depends, as you said, if they've got reactive airways, as a guide to the overall fluid assessment. I would be using the other parameters that we normally use, looking at the capillary refill time examination, how much edema is the patient got, prolonged capillary refill time, and also if they've got a CVP line.
Thank you, sir. So our post-operative management for the first 3 days for this kid, as per our unit's protocol, vital parameters are continuously monitored, of course. The CVPs are monitored every hourly, the blood pressures likewise, and we target around 8 to 10 centimeters of water pressure, sticking on the higher side 10 to 12 for the first day. The urine output is monitored hourly, and it serves as a very important guide towards replacements, and the drains, which was put in this case, the output was monitored every 6th hourly and accordingly replaced. So the fluids are very stringently measured and guided by the hourly urine output, where outputs more than 500 ml are replaced equally for the first 24 hours, and subsequently over the next 2 days, the second and the third day post-transplant, we try to achieve some amount of negative if the child is polyuric, pouring out more than 500 ml per hour. The electrolytes are also very stringently monitored, and appropriate corrections are made for both values above and below the normal range. We cover preemptively with antibiotics. Ceftriaxone and amoxicillin clavulanic acid are the drugs of choice for our unit, while simultaneously tracking the sepsis markers and sending appropriate cultures. For live transplant, the cultures are sent -14 and -7 day pre-transplant, whereas in case of cadavers, they are sent on the day of transplant, and further cultures will be guided upon clinical response. And for pain management, we are not very happy with epidural. Other than that, we do give paracetamol round the clock, and opioids are administered on SOS basis. Antihypertensives, you have already enlightened us as to what monitoring should be and what drugs should be of choice. Anticoagulants, low molecular weight heparin is started preemptively only in situations wherein underlying hyperthrombotic state is present, or as guided by the surgical indication if vessel condition demands. And in our kid, we had not started on any anticoagulation. Prophylaxis, antiviral, antifungals, and PCP prophylaxis are administered between day 3 and day 5 after monitoring the counts and the baseline transaminase values. So first graft Doppler is done within 24 hours of transplant, and a repeat value is done after 24 hours of drain removal and DJ removal, mandatory. Other than that, as guided by the clinical laboratory indications, urgent graft Doppler is available. The normal graft perfusion with the RI of 0.67 was documented for our kid first day post-transplant, and the further follow-ups were also within normal limits. The immunosuppression choice, grapholon, 7.5 milligrams per kg of total dose was given, because at this time, thymoglobulin was not available nationwide. Methylprednisolone, 10 plus 10 plus 5 milligrams per kg per dose on day 0, 1, and 2 of transplant. This was followed by the CNI-based triple immunosuppression regimen. Tacrolimus was given in a dose of 0.075 milligrams per kg per day to begin with, and we achieved a decent TAC level of 9.3 with this. Our targets are to keep the values between 10 to 12 immediately post-transplant. Morphicon OS suspension, which is available in our pharmacy, came to our rescue as far as MMF administration was considered, and starting from a 700 milligrams per meter square, we went up to 950 milligrams per meter square by day 15 post-transplant. And oral prednisolone 1 milligrams per kg per day was continued after methylprednisolone. So your comments on the post-operative management, the monitoring, and your unit protocol as far as anticoagulation use is concerned.
Yep. So again, excellent questions, and I think your post-operative management generally is very good. We invariably would be going through the same management as you said with your vitals. We would have insensible losses plus the urine output. I would only really replace the drain output if it was excessive amounts, as you said, or if there was a lot of blood loss. We would be, again, it depends on the native urine output as to how much replacement that we give. Initially, very often, we would give 100% of the urine output replacement and then start cutting back. But as you said, if the child, for example, was polyuric beforehand, you know, you might want to be careful about the total amount of fluid that you're giving as well. So I think your fluid and electrolyte management is good. The one thing to say with the pain management is we're doing quite a lot of transversus abdominis plane blocks, so TAP blocks in patients where intraoperatively they're putting in a TAP catheter, so a catheter through the transversus abdominis plane muscle, and then basically we instill some anesthetic, and then in fact you can have an ongoing infusion which can go for the first 24 hours or so post-transplantation, and we find that that has reduced the requirement of using opioid analgesia, and obviously less nausea, less sickness, and an increase in mobilization as well. You also were asking about anticoagulant therapy. So I see all the patients and families before going forward for transplantation, so either going on call for deceased donor transplant or a living donor transplantation. And in those situations and scenario, I would be speaking to the families and checking a good past medical history or family history as well of episodes of thrombosis or bleeding. So specifically thinking about deep venous thrombosis in first-degree relatives, pulmonary emboli. And we would also be in the situation of having a good questioning about family members with recurrent miscarriages, for example, any bleeding tendencies around pregnancy, so antepartum, postpartum hemorrhages, the requirement for blood transfusion during pregnancy or afterwards as well, and using those as a marker to delineate which patients we might want to do further testing. But if there's no personal history of bleeding or thrombosis, and a patient's had operations themselves, then that is one thing. If there is a normal coagulation screen, so prothrombin time, APTT thrombin time, and fibrinogen levels are normal, in those patients we would just give aspirin peritransplantation, and we would give that for the first month. If there is a family history or past medical history, then we would instigate doing some further procoagulant screen, so looking to see on risk factors, and depending on the risk factors, we may modify the aspirin to have, in addition, intravenous heparin. We would generally try and give the intravenous heparin when the surgeons were happy that there was no bleeding post-transplantation, and sometimes we'll give a small infusion not to correct the APTT, but just to make sure that the blood is a little bit thinner. And it means that if there was any bleeding, it can be quickly reversed with protamine sulfate. Apart from that, you mentioned covering with intravenous antibiotics, and I think comoxiclav is reasonable. We would give valganciclovir prophylaxis only for patients with high risk, so donor positive CMV into recipient negative CMV. We wouldn't routinely give fluconazole, but would potentially give nystatin if the patient was on lower and was on antibiotics for a longer period of time, for example, as you said, a positive culture. And we would give cotrimoxazole therapy for at least 6 months, which would prevent against PJP infections, but also, as you said, would prevent against urinary tract infections as well. You also mentioned about an initial recovery ultrasound, which we would do, and I think that would be important. If there is a very small recipient, when you're asking about the anticoagulation plan, we'll have a lower threshold, especially if there's been any concern with any of the vascular imaging, to do a procoagulant screen within them. And sometimes, as I said, it would be aspirin with intravenous heparin as well. As for immunosuppression, generally, I would give ATG, thymoglobulin, or alemtuzumab to high immunological risk patients. But for low or medium immunological risk patients, then I would give what we refer to as the old TWIST protocol from our randomized controlled trial internationally. And in this situation, what we do, we would be giving patients intravenous basiliximab, so anti-CD25 monoclonal antibody on day 0 and day 4 post-transplantation. I would then give them mycophenolate mofetil and tacrolimus initially, and give up to 1.2 grams per meter squared per day. It's in 2 divided doses of mycophenolate mofetil, and then reduce that 2 weeks later to half that dose, assuming that there's been no concern about rejection or renal allograft function. We then start with tacrolimus, and I don't wait for the creatinine to come down. And tacrolimus, I would aim for initial trough levels, usually kind of between 8 and 12, so kind of 10 to 12 mark, initially aiming for. And in those patients with that are low medium risk, I would only give a 5-day course of corticosteroids and try and wean them off steroids pretty quickly afterwards.
Okay, sir. Sir, about tacrolimus, in our experience, a lot of kids are rapid metabolizers. Even this child down the line, he is now 11 months post-transplant, and 3 months onwards, we have been really struggling to keep up his TAC levels in the target trough values. So in situations like this, how do you manage?
Yeah, it's a very good question. So normally for the first 2 months, I'd be aiming for, as I said, a trough tacrolimus level between about 8 and 12 nanograms per mil, and then reducing it if there's been no rejection to between about 5 and 8 nanograms per mil from month 3 all the way through the first year, and then kind of individualize that. We are in the situation that if you've got a patient and we are running into difficulties with the tacrolimus level, is I would think about doing an area under the curve. Obviously, the first thing to consider is the patient actually taking suppression? Do you have a problem? And as you said, or is it just the fact that you've got somebody who's a rapid metabolizer, which I think is also important to consider. And in those situations, if we're really, really happy, then we would do the tacrolimus profiling. And there are different ways of doing this. The best way is if you've got somebody who's an inpatient, where you can take a trough level, a level at 1 hour, 2.5 hours, 6 hours, and 9 hours, and then you can work out the area under the curve with a relatively, high value for the variance of being about 99%. If you're in the situation that the patient's not an inpatient or is more difficult, then you can do blood tests with a trough level at 1 hour, 4 hours, and 12 hours, and that will give you a variance of about 92%. Whereas if you just do a 4-hour level to see what the peak is, then the variance is only down to 73%. So I would advise doing the area under the curve if you want, and I can give you the formula to try and calculate what that is by using the more frequent one, and I can put that in the chat if you would like.
Please do so.
So it's quite a complicated formula. So it's 2.68 plus, you take the 1 hour peak level, you multiply it by 1.23, you add it on to the 2.5 hour level, multiplied by 1.62, you add it on to the 6 hour level, multiplied by 5.5, and you add it on to the 9 hour level, and you multiply that by 3.44. And in those situations, you're kind of aiming for an area under the curve round about 100 micrograms per hour per mil, which usually corresponds to a trough, which is between about 5 and 8. Kind of variance makes it between about 4 and 12.
Right. So in situations where the desired area under the curve is not achieved, do you see any role for thrice a day dosing or strategies, other than just keeping on increasing the dose? Because this kid has reached a dose of around 0.25 milligrams per kg per day of tacrolimus, and still we are struggling to keep up the levels. He's 11 months post-transplant, and the level is between 3 and 4, the trough levels.
So, so we have been in the situation. It's used a lot in the developing and developed worlds, so different nations. But fluconazole, as an antifungal agent, can augment the tacrolimus concentration by decreasing its metabolism. And so we've been in a situation before where I've added in fluconazole in patients, as you said, that are rapid metabolizer and managed to get their levels up a little bit. So I have done that.
Right. I'll quickly just sum up the post-transplant course. So by day 4 post-transplant, a little hurdle, the hemoglobin dropped from 8 to 5, and although some of it was contributed by dilutional effect of the large volumes of fluid administered, the child was growing tachycardiac and tachypneic, so irradiated PCV was transfused via a leukocyte filter. Day 6 post-transplant, the drain outputs increased with parallel decrease in the per-urethral urine output, and the fluid as well as the urinary creatinine indicated towards a urinary leak. The child was opened up, and the surgical team found a lower ureter necrosed, and a ureteric reimplantation with BJ stent inserted this time around was done. By day 10 post-transplant, after this surgical complication, the child developed a Klebsiella urinary tract infection, symptomatic with cultures positive, and meropenem and colistin treatment was administered for 14 days duration. On day 15 post-transplant, he achieved his nadir creatinine of 0.2. Day 30 post-transplant presented with high-grade fever, and this time around COVID cases were peaking. So the test was done for him, which suggested COVID-19 positive. Apart from fever, he did not have any other significant lower respiratory tract infection, and he was conservatively managed. He came out unharmed. Day 50 post-transplant, as a routine screening, graph Doppler was done for asymptomatic child, no drop in the urine output, no hematuria, but this revealed a partial thrombosis in the renal vein, the graft renal vein. for which surgical consult was done, and decision was to conservatively manage with anticoagulation. He received a treatment dose of lower molecular weight heparin for 3 months, followed by 3 milligrams per kg lower dose of aspirin, which was continued for 3 months. On day 60 post-transplant, as is our unit protocol, we did a screening for CMV infection. We screened for CMV, BKV, and for EBV, viral infections. And on that, we identified that CMV infection had been brewing, and we treated it with the valganciclovir treatment doses. Parallelly, around this time, child developed a episode of high-grade fever with some dysuria, and the urinary cultures were positive, so IV antibiotics were administered. The SABA screening was done, single antigen bead assay screening was done to pick up immunological activity, and class 2 DQ positivity in MFIs of 4,000 was identified against the donor antigen. And this was addressed with IVIG administration and a parallel graft biopsy performed. Since there was no histopathological change to suggest underlying rejection, the treatment was restricted to IVIG administration and optimization of the oral triple CNI-based immunosuppression regime, and no further aggressive immunosuppression was given, with the background of the infection CMV UTI coexisting around the same time. Between 6 to 9 months, the child has had 3 more episodes of urinary tract infection, all requiring IV antibiotics. Surgical consultation has been done, and MCU was also performed, which suggested low-grade reflux into the graft. And the surgeons opined that we need to carefully monitor the further course with uroprophylaxis. So he's continuing Septran even 6 months after transplant. So that's about his course. Now, currently 11 months post-transplant. The last 10-month follow-up, his creatinine was 0.48 milligrams per deciliter, presently on a dose of 0.25 milligrams per kg of daily tacrolimus in 2 divided doses, 1,000 milligrams per meter square of mycophenolate mofetil, and his prednisolone, we've come down to 5 milligrams now, which is around 0.7 milligrams per kg per day. And this is his growth chart, which shows good improvement from his course pre-transplant, with the weights creeping up into the 10th centile brackets, and the height gain is also much better than his pre-transplant course. Thank you. I invite Dr. Anshuman Saha to please take over and engage with the other speakers. Thank you.
Thank you very much for the presentation. Can I just ask you one quick question? I'm sure it's fine,
Sure.
but you just mentioned that he had the ureteric reimplant with a double J stent on day 6, and then the Klebsiella UTI on day 10, and then recurrent UTIs day kind of 6 to 9 months. I presume the double J stent was removed.
Yes, sir. It was removed. It was removed 15 days after.
That's fine. Okay, no, because I've been in a situation where people have forgotten that they've gone back and put in a double J stent, and it's been left in for a few months and not realized. So that's great. Thank you.
Yeah, thank you, Dr. Sanas, for that presentation, and Dr. Marks for answering all those questions very gracefully. And now I ask the chairpersons if they have any comments and questions for the case.
Yeah.
Yes, Dr. Bina, please.
Yeah, thank you, Dr. Mark. It was very enlightening answers and talk from you. And we are giving this TAB block very regularly in adult patients, but usually in this small 10 kg baby, we have not yet given. So, but now we'll start giving TAB block for the pain relief after your guidance. Thank you.
I normally, as what to do is if you're doing it in the larger patients, we start bringing it down to those that are kind of 40, 50 kilos. You do a few of them, and then go down. I mean, obviously, if they're intra-abdominal, it's different, but if you're going on to the ILACs and you've got a tap lock, then we definitely do see an improvement in the requirement of opioids. So I would agree.
Yeah, in adult patients, we are giving very regularly tap block, but now we'll start using in even small babies. Yeah, thank you.
Great.
Yeah.
Dr. Umali?
Yeah, Dr. Marks, thank you for bringing in so much clarity on so many small issues. I have some simple questions to ask. How much does leukodepletion and irradiation of blood reduce our risk of sensitization? Would you say, does it eliminate it or just reduce it? Or
It definitely reduces it. I have to say that it's mainly the leukodepletion as opposed to the irradiation, and many countries now are finding it more difficult to get fully irradiated blood for all patients going forward for kidney transplantation, because they've got kind of active bone marrow units and, more, wondering about CMV. We went through a period where we trialed leukodepletion of blood and then putting them through a secondary scenario, which is called wash cells. So basically you try and remove more of the antigenic material from the cells as well. And we found that even by doing this, which was actually much more expensive and timely, it didn't actually reduce the immunogenicity. The other thing is sometimes people forget that patients can get sensitized to platelet transfusions as well as blood transfusions. So in the situation that you're making sure that the blood is fine and then they get sensitized. One potential thing to try and do is to, and I don't know what provisions that you have in your unit, is where you have the HLA typing of your recipient, but you try and get close to the HLA typing for when you do a transplant. Now, in the United Kingdom, that is not routine. So in other words, HLA typing of blood donors is not done routinely, but it is done in a subsection of those that potentially when they're looking for bone marrow transplants in the future. So there are a small pool, and it's not saying giving HLA identical because that's near enough impossible, but a closely HLA matched blood can sometimes help. But to be fair, one of the most important things is the fact that if you've got a patient that is requiring 3 blood transfusions, is it possible to make sure that they get it from the same donor? So you're not keeping every single time you give them a blood transfusion, you're not increasing the antigenic load by different antigens every single time. And again, that sometimes is feasible, but very often it's not. But it's something to consider.
yeah, so I think that would be a little distant away for us to get that in place. But what I understand is that the leukocyte filter that we use does not really do the job. That this is the leukocyte depletion which the blood bank does and gives us, right? Yeah. Another question I wanted to ask about the intraoperative: is it routine in your unit to put in a DJ stent, or you don't put a DJ stent, or?
Yeah, very interesting question. So we routinely do. We also published a trial that we did where we randomized patients, and I would put the caveat that this didn't include patients with hostile bladders, so it wasn't any of the infants that had ureterostomies or posterior urethral valves, for example. And we randomized them to 2 methods. One is where the double J stent was inserted and tied to the end of the urethral catheter. And the other group was where we did the routine, where we just put in the double J stent. And the idea is that in those that are randomized, where you attach the double J stent to the urethral catheter, usually at around day 5, when you remove the urethral catheter, the double J stent then comes out with. Now, that almost always obviates the problems. Obviously, we put a double J stent in to prevent obstruction. Keeping it in increases the chances of infection. Most obstruction is going to be initially. So I'm a I'm very in favor of this for most patients, but it's very surgeon specific. So even within our unit, there are some surgeons who never liked doing it. It just felt like an additional task, which was more complicated. We were also in the problem when we were doing the trial, and then subsequently when some patients were having you trying to remember who's got a stent and who doesn't, whereas you have to think that if you've got a stent and everybody, then everybody needs a removal, and sometimes that's easier to have a protocol. But the answer is yes. I have discussed with the surgeons your other question, which is, would you consider not putting stents in patients and then only putting in the ones that run into complications? And it's not been seen favorable. So no, we always put in stents.
Okay.
But many units don't.
We have two transplant surgeons, and one chooses to put a stent and the other does not put a stent. And also, so I mean, we've not seen anything worse in the ones who don't have a stent in place.
Yeah, so it's quite common as
that was a surgeon's choice.
Yeah, we're quite common in many adult centres not to put stents in at all in any patients. We also were in the situation when I first started 25 years ago, there was just one surgeon, but then when he retired, we had two surgeons, and it was exactly the same. One put in the stent that would come out at day 5, and the other one would keep the stent in for at least 6 weeks. And again, it's very difficult unless you do randomized control trial and you've got the same person doing it. It's a bit difficult, but yeah, I think that many patients potentially could get away. There is also newer techniques where there is a stent which you can actually remove without having an operation by the magnetic field on it and getting it attached and coming out the body. So some units are beginning to do that, but that's a bit trickier in small children.
So we also have
one more question regarding intraop fluids is, do you now use balanced solutions, or you use saline in the crystalloid component of
So we're just at the process of analysing the data from the study, the Pluto study that I told you about, using plasma light. Obviously, the physiological concerns people have are about the development of hyperkalemia that you talked about in your case, because obviously you're giving potassium when you're giving some of these solutions such as plasma light. But actually, physiologically, it makes more sense. And actually, when it's buffered, you don't tend to get the hyperkalemia. But we were in the situation where some centres wouldn't even advocate being part of the trial because they thought the risks were too high. And other centres wouldn't use anything apart from normal saline or half normal saline because that was their standard employed. But remember, when you give, high amounts of sodium chloride and the volumes that we sometimes give in these patients, the development of hyperkalemic metabolic alkalosis, you've got to look at the risk benefit of that as well in patients. So I think it's taking the whole situation on top, which is actually really important as well.
Lastly, I'd just like to share that in two patients, one for a live donor transplant and one for a cadaveric transplant, we had taken the recipients with very low ejection fraction. In the live donor transplant, it's because the compliance with fluid intake was very poor, and he would come repeatedly with pulmonary edema, and it was felt that probably he'll be better off with transplant than continuing with dialysis. The option of home dialysis as of now is not there in pediatric patients. Maximum we can do is 4 times a week dialysis in hospital.
Same for us.
And he had about a 20% ejection fraction. And the second was a bigger girl. She was 14, 15, and she also had an ejection fraction of 20%, and she had a cadaveric kidney which was available for her. And I was very hesitant, but our adult nephrologist team told me that, what is your option if you don't transplant her? She's just going to get worse. With her cardiac is never going to improve with this kind of a thing. And so under high risk consent, we took. And both of them did well. My concerns were, of course, perfusion of the graft, hypotension due to myocardial depression with anesthetists, etc. And subsequently, on speaking to other pediatric nephrologists from India before and after that, apparently some centers have faced the same thing and taken this kind of decision because cadaveric kidneys in our state is not so easily available. So if somebody got within 1 year, we would say they're very lucky. Most of them wait many years.
Yeah, no, I completely understand. And for me, historically, before we had, our large home hemodialysis program that we've got now, we definitely, I remember transplanting a patient where the cardiac function was poor. I have to say, there's always risk benefits between living donor and deceased donor. The good thing about living donor is it's on a planned date. You've got the anaesthetists around, so the perioperative management. The problem with deceased donor is you might, have a anaesthetist the weekend and it's their first kidney transplant they've ever done, for example, in a small child. So you might be a little bit more wary. So I think it does depend on, the situation and the transplant that you do. But as you said, sometimes you can get improvements, and once you've taken the salt and water overload, again, you can still get remodeling and improvement in left ventricular hypertrophy and improvement in the cardiac function with time as well. We've also been in the situation where some children, for example, with bilateral Wilms tumor, and then they get cardiotoxicity following the chemotherapy. That can be quite tricky to manage. And actually, even on home hemodialysis, we've had some patients that have had improvement in their cardiac function as well.
Thank you so much.
No, thank you for your interesting questions and interest.
So, sir, coming back to the DJ stent, so if the DJ stent would have been put from the beginning, so would it have prevented the ureteral lower end ureteral necrosis?
I think the answer, if there's no surgeons in the audience, I think the answer is it's more likely a surgical issue, isn't it? And actually probably inserting a DJ stent at the very start wouldn't have made much difference. Obviously when when they're doing the transplants and you're going in, it's very easy because you're getting rid of the lymphatics and the small vessels, but we know that the distal ureter is always at risk. Yeah, it's very, because of the blood supply, it's very tricky. And very often the blood supply is a little bit reduced. So I think it wouldn't have been prevented in this particular case,
And that also led to the UTI, first UTI. Subsequent UTIs could be due to the immunosuppression part. Exactly. But the first UTI was obviously, it was due to the that complication, and that required for the child to go back to the OT also again. So a very nice discussion, sir. So we are very thankful for this.
No, thank you very much for inviting me.
We learned a lot from the discussion, and I thank Dr. Umali Madam and Dr. Bina Madam who joined with us and also had asked beautiful questions. And I hope everybody enjoyed and learned from the session. So I would like to conclude this session. Thank you everyone. And
thank you very much indeed. And I hope to see you all because I'm hoping coming to Calcutta for the Indian Society of Organ Transplantation. So hopefully I will see you in India at some point soon.
Oh, we are eager to meet you, sir. Thank you.